Thank you very much for time this morning, and thank you to the conveners of the conference for the invitation and the already delightful conversation here. That's not mine. I'm going to just jump right into my paper on healthcare institutions and the practice of moral reason. I am the proud father of 3 boys, 9, 5, and an infant who's 8 weeks old. My wife, when I arrived in Heathrow, I sent her a screenshot of the weather in 60 degrees Fahrenheit, and she sent me back a screenshot of the weather in Dallas, and it was 106 this week, and she said, "You chose a good week to be gone," which was not a congratulatory text. All 3 of my sons were born via C-section, the first an emergency delivery that ranks among the most frightening hours of my life, in which I was left alone in a hallway in the back of a hospital, wondering if my wife and or son were alive. The most recent delivery was an excellent experience, scheduled on my mother's 67th birthday, and I think that he may now be her secret favorite of her 12 grandchildren because they share a birthday. But it is the birth of my middle son, Silas, where I want to begin. The procedure itself was routine, no complications, no surprises. I was positioned at the top of the bed near my wife's head while the surgery took place behind a little makeshift tent. While we couldn't see what was happening, we could hear everything. And one of the things we heard as the surgical team was closing up the incision was a conversation they had with someone who was there, like a resident or a fellow. In any case, she was engaged in a long journey of medical education and was only there to observe. I don't remember what her title was or anything. And they asked her what she had to attend that day, like what sort of training, that sort of thing. And she replied, "Ethics training." Both of the senior doctors laughed and immediately dismissed it as a waste of time. My question is the response of these doctors evidence of corrosion in the sense that this conference conceives of it? That is, does the fact that these doctors see ethics training as a waste of time indicate that their, quote, capacity to develop a well-ordered professional identity, end quote, has been corroded by their formation as medical practitioners? Or is training in bioethics, not in fact a requirement for proper formation as a medical practitioner? Now, this, I think, is actually a more complicated question than appears to be at first blush, especially in a room populated with ethicists. Because the senior doctors in the room are in the good company of senior professors of ethics like Alistair McIntyre and Stanley Hauerwas, who think that ethics as taught in medical settings rests on a mistake. That's a quote. In what follows, I take up this challenge of the formation and corrosion of medical practitioners as ethicists, arguing that both the doctors at my wife's bedside and the McIntyrean criticisms are wrong, though the latter at least helpfully point out limitations of contemporary bioethics. Bioethics, that is neither a waste of time nor does it rest on a mistake. Medical practitioners who cannot reason morally about the challenges that present themselves in the practice of medicine are inadequately formed as medical practitioners. They are corroded. This part of my argument, however, is only implicit. The explicit argument is about the importance of institutional norms for moral reasoning in healthcare. I assume, rather than argue, that inadequate attention to healthcare, to ethics, is a form of corrosion. But the McIntyrean critique also makes it clear that there are poor versions of ethics that, when taught and or practiced, can also be corrosive. And I address this concern directly. 2 of the conveners of this conference, Ashley and Josh, thank you again for inviting me, have recently deployed arguments that I think have family resemblances with the McIntyrean critique. Both have to do with the demands of public reason, one in healthcare resource allocation, this is Josh's, and the other in clinical ethics, this is Ashley's. And I'm in broad agreement with those arguments, but I want to defend a version of public reason-inflected bioethics, ironically perhaps, by arguing for institutionally based forms of ethics that operate with thicker accounts of the good. To put a fine point on it, I want to argue that the putative neutrality of public reason is a political aspiration and approximate provisional political achievement, not a natural or a final state. The mistakes in bioethics, identified by critics like the two I'm interacting with here, rest at least in part on not understanding neutrality as a political aspiration and achievement, and assuming rather that the demands of public reason should properly govern all moral deliberation in any context whatsoever. On my telling, this means that properly understood, official political neutrality is putative. The putatively neutral political order holds the space for non-neutral, committed institutions. This is true of, for instance, educational institutions, for-profit publishing businesses, and others, but my focus here is on medical institutions. The norms of committed institutions will inevitably, perhaps necessarily, conflict. So think of institutions that take different approaches to physician-assisted suicide. But developing institutions with clear commitments is important for enabling medical practitioners to reason morally, even when those practitioners disagree with the norms of their institutions. So brief section 2, background and sort of sources and scope of the argument. So my paper emerges both from a long-standing partnership my own institution has with Houston Methodist Hospital, from which I've learned a great deal about healthcare institutions, and from what were called listening sessions that one of my colleagues at another institution, Auburn Seminary, and I conducted with chaplains, ethicists, attorneys, and senior administrators in medical institutions, in which we asked them about how they reason about and make decisions in difficult moral cases. The most striking feature of those sessions was how frequently the different practitioners appealed to the norms of their institutions, even when they disagreed with those norms. This suggests that one important source of corrosion in healthcare practitioners is a lack of institutional norms, or to use a loaded and notoriously amorphous term, culture. There are presumably a large number of challenges to building institutions with strong moral frameworks, strong norms, goals, values, or culture, and taking seriously the critiques of dogmatic accounts of public reason in bioethics suggests that one main challenge is precisely the temptation to force all forms of moral reasoning in healthcare settings into the constraints of public reason. My argument engages the challenge of public reason in healthcare in two ways. The first has to do with how healthcare institutions exist within the context of liberal democracies. This has to do with the ways that institutions reason in relation to the larger society. The second and related part is about the tools that bioethicists use to analyze cases. This has to do with the ways that healthcare institutions reason internally. Now, these are intrinsically related because the concerns about the ways public reason shape the discourse around healthcare and the larger society is replicated in the critiques from various corners of the discipline to the principalism of Beecham and Childress, the kind of dominant approach to bioethics. So, section 3, committed institutions in neutral societies, and this is a brief section. Regarding the first challenge that I just raised, that of public reason as such and its relation to society as a whole and then to particular institutions, briefly consider 2 points. First, John Rawls himself delimits the scope of the demands of public reason. In Political Liberalism, he writes, and this is an extended quote, "A well-ordered democratic society is neither a community nor more generally an association. There are 2 differences between a democratic society and an association. The first is that we have assumed that a democratic society, like any political society, is to be viewed as a complete and closed social system. It is complete in that it is self-sufficient and has a place for all of the main purposes of human life. A second basic difference between a well-ordered democratic society and an association is that such a society has no final ends and aims in the way that persons or associations do. Here, by ends and aims, I mean those that have a special place in comprehensive doctrines. By contrast, the constitutionally specified ends of a society, such as those given in a preamble to a constitution, must fall under the political conception of justice and its public reason. This means that citizens do not think there are antecedent social ends that justify them in viewing some people as having more or less worth to a society than others and assigning them different basic rights and privileges accordingly." Close quote. So there's warrant here in Rawls himself for distinguishing between the kinds of reasoning demanded in democratic societies and the various kinds of reasoning permissible in associations that exist within, and we may assume partially constitute, those societies. Public reason is the form of reasoning demanded in democratic societies because it conforms to the basic political conception of justice that treats individuals as free and equal, as having what he says in that quote above, equal basic rights and privileges. What Josh's work has recently pointed out, however, is that, and this is a quote, because Rawls himself lists basic health care for all as something required as a matter of basic justice, health care falls within the scope of public reason. And this brings me to my second point. While we may distinguish between democratic societies and associations and the kinds of reasoning that attach to both, healthcare as an overarching concept seems to occupy both spaces. The challenge for present purposes is determining in what respect, if any, public reason is the required form of moral deliberation in something called healthcare. Now again, drawing on Josh's article, I think that he's argued convincingly against a dogmatic position that requires narrow forms of public reason in relation to healthcare resource allocation. But that argument is both about a form of healthcare, the NHS, that is more obviously an institution of a democratic society than it is an association, which may be possible in the United States context where I'm from, and it's based at least in part on a kind of imminent critique of the dogmatic position about public reason itself. By cordoning off religious reasoning, he argues, the dogmatic position fails to engage, quote, with a religious or cultural community's internal arguments that may improve healthcare commissioning, end quote. An argument based on improving healthcare commissioning is an argument that seems to satisfy the conditions for public reason. What about institutions that are not so clearly part of the official political order? Institutions that are, in Rawls's vocabulary, associations. What sorts of reasons can these permit for internal deliberation about moral questions? Here we come to the center of the inquiry, I think. And I should pause here and say that this is the difference in political context between the UK and the US really comes to the fore here because the institution that I work most closely with, Houston Methodist Hospital, is one of the remaining Protestant-owned hospitals in the United States. You have Catholic healthcare hospitals, you have these sorts of things, but the Methodist Church actually, the Houston Methodist Hospital is still an extension of the Texas Annual Conference of the United Methodist Church. And so it actually does fit the kind of definition of an association in a particular way. But it also has 32,000 employees exist within the state of Texas in the United States. So even there, you're talking about significant overlap with the legal regime, or political regime. So how are practitioners to reason about difficult moral cases in clinical settings like this? Does case-based ethics require practitioners to operate with exclusively a thin theory of the good? Does the right take priority over the good in clinical ethics? Can institutions as associations operate with, and thus provide to their members, a thicker account of the good than can the official institutions of democratic societies? My answer to this set of questions is a halting but clear yes. Halting because I take seriously the concern raised above about how healthcare occupies space in both the official political arena and the associational arena. Where clinical ethics finds itself involved in the process of reasoning with, say, the courts, the practitioner may need to conform his or her arguments to the demands of public reason more closely than it does in other situations, but this would bring us back to the critiques of public reason in healthcare more broadly that I've just been discussing. For more standard cases, however, and this brings me to section 4, practitioners may be expected to reason within the frameworks of healthcare institutions in which they practice. And these frameworks may be indexed to a much thicker account of the good than the account available in the democratic society within which they exist. In institutions as associations, the good may have priority over the right. But where do these accounts of the good come from? What's the provenance of them? My working thesis is that institutions are bearers of traditions that have in many cases been buried like ancient cities under layers of historical and cultural sand. The cultures and traditions that birth them have lost at least some of their intelligibility due to the inevitable shift in cultural norms. They operate at a more or less conscious level with institutional values or norms that reflect commitments to substantive, usually religious traditions, no matter how anodyne those commitments may be expressed in the truncated vocabulary of marketing, legal, DEI, and business offices. If this is the case, then it makes good sense why practitioners instinctively pivot to the thicker institutional norms when they're making decisions. They not only need to conform to institutional policies in order to keep their jobs, but they are provided thicker frameworks within which to reason. In what way are these practitioners to reason within the institution, even and especially when the norms of the institution are asymmetrical to their own? I think that this brings us right to the core of case-based bioethics. And that is, case-based bioethics is what one thinker has called a godchild of Rawlsianism. So how can it cohere with an account of healthcare institutions in which the good is prior to the right? I want to try to answer this question by arguing against two different ways of thinking about case-based ethics. The first is the McIntyrean way that I've been describing or gesturing at. The second is a reductionistic form of clinical ethics that treats autonomy as trumps. The former expects too little from clinical ethics, the latter too much. So McIntyre, expecting too little. The McIntyrean critique I've been referencing is drawn primarily from McIntyre's 1984 article, Does Applied Ethics Rest on a Mistake? To which the answer is yes for him. The presenting concern from McIntyre in this article is an oddity observed in the National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research, in which the commissioners, here's a quote, found it relatively easy to reach agreement on, or in a minority of intractable cases, at least local disagreement on particular concrete issues raised by specific difficult types of cases, but continue to have fundamental and radical disagreements on matters of moral principle, on what the rules of morality actually are, even though each of them individually aspired to justify his or her views on the concrete issues by appeal to his or her principles. So unsurprisingly for McIntyre, this is part of a larger argument about moral fragmentation in modernity. Fragmentation that is ironic because it is cast in universal terms as an attempt to conceive of ethics in terms of morality as such, as that which concerns what is true of everyone and anyone in their capacity as rational persons. Put this way, we can see the Rawlsian sort of heritage here in bioethics in a particularly clear way. If it is the capacity of as rational persons that gives morality its purchase, then tradition-based reasoning is dead on its arrival at the clinic. And principlism does in fact aspire to be the kind of reasoning that any rational person would be willing to accept. So in Principles of Biomedical Ethics, the standard textbook, the authors go to some lengths to clarify what they mean by, quote, common morality as universal morality, end quote, and how the, quote, moral norms central to biomedical ethics rely on the common morality, end quote. At the same time, however, they also go to some lengths to clarify the limits of principlism, arguing that, quote, in contrast to the account of moral obligation offered by these theories, by which they mean something like totalized Kantianism or utilitarianism or something, we maintain throughout this book that various moral principles, rules, and rights can and do conflict in the moral life. These conflicts sometimes produce irresolvable moral dilemmas. When forced to make a choice, we may resolve the situation by choosing one option over another, but we may also believe that neither option is morally preferable. Explicit acknowledgement of such dilemmas helps deflate unwarranted expectations about what moral principles and theories can do, end quote. So setting aside the debate about the existence of moral dilemmas that they sort of put on the table, their account of principlism is explicitly deflationary. Principlism is, on their telling, an analytical framework, here again a quote, of general norms derived from the common morality that forms a suitable starting point for reflection on moral problems in biomedical ethics. So the literal textbook account of principlism sees it as a starting point for reflection and assumes that it will not deliver all of the answers all of the time. It may not deliver an answer at all. Instead, it may do little more than bring the practitioner to a point of decision-making, having only helped clarify the equally morally unpalatable options between which the practitioner must choose. Very clearly in the background of both McIntyre's critique of applied ethics and the account of principlism is a debate about casuistry. McIntyre's argument rests at least in part on the assumption that the dominance of liberal forms of thought in contemporary applied ethics lacks a tradition that makes principles intelligible, and that such a tradition is required for casuistry to work. Thus his confusion at the ability to reach consensus while disagreeing on rules and principles. McIntyre writes, "The indeterminacy of our principles or rules is such that they do not in any substantial sense at all bind us. This is why these are not genuinely moral principles or rules," end quote. And in a telling next paragraph, right near the end of the article, McIntyre offers this caveat. "It is crucial to reiterate that I am not here speaking of the principles or rules of those clear-headed adherents of highly determinate moral standpoint who provide our society with its deviant moral subcultures. Catholics or Southern Baptists, pacifist members of the Society of Friends, or radical feminists." If you can locate yourself in any of those four categories, right? What I'm speaking of are the simulacra of moral principles that are what moral principles are transformed into in the great pluralist mishmash of shared public life of liberal societies, end quote. Stanley Hauerwas picks up on this point in his essay, Casuistry and Context, The Need for Tradition. Hauerwas argues that, quote, "the intelligibility of casuistry depends on a tradition-formed community constituted and sustained by a particular set of virtues," end quote. And so it follows for Hauerwas that we cannot have casuistry, as he put it, as such. It can't be just commended to us, but rather, as he puts it explicitly following McIntyre here, quote, "the casuistry of Catholics or Southern Baptists," end quote. Though Hauerwas admits these are, quote, "very different casuistical traditions to be sure," end quote. Noting that Roman Catholic and Southern Baptist traditions are very different is an important caveat. On the one hand, our location here, less than a half a mile from the Martyrs Memorial, might remind us that the political framework in which members of those traditions can coexist without resorting to making martyrs of each other is one we should be very reluctant to abandon. And that framework in which we don't make martyrs of each other based on our traditions is, to put a very fine point on it, I know, liberalism. On the other hand, it also raises a question about what kind of thing a tradition is. And I certainly can't answer that question here, but I'm unconvinced that inhabitants of liberal societies simply do not have access to traditions adequate enough to make casuistry operable. This, I want to suggest, is what committed institutions are offering to their practitioners. This is why the Southern Baptist tradition is up to the task. So why is it that the Southern Baptist tradition is up to the task, but a healthcare institution is not? Put this way, the problem with the McIntyrean critique is that it expects too little from principalism. It thinks that because principalism is without a tradition, it cannot help us reason morally. Section 2 here, subsection 2, on expecting too much. And I'm going to interact here with a thinker named, a bioethicist named Janet Malik that is the target of Ashley's critique. The inverse, I think, is to expect too much from principalism. And this brings us very close to his critique of Janet Malik's what she calls programmatic secularism, and that's the label. For Malik, in the work of clinical ethics, the practitioner brackets out any personally held religious beliefs. The tools of the trade are rather a kind of rigorous principalism in which principalism is a kind of in-house version of public reason. In Rawlsian terms, this assumes that the right has priority over the good, not only in official public political deliberation, but in non-public associational moral deliberation. While thinkers like Malik may not expect principalism to provide moral certainty, they clearly expect more from principalism than what Bishop and Childress think it offers. And if Bishop and Childress have a deflationary account of principalism, the position I am attributing to Malik is an inflationary principalism. One reason inflationary principalism expects more from principalism is that it takes the principle of autonomy as trumps. Once patient preferences have been established and deemed authentic or trustworthy or something like that, the case is almost always concluded. As Malik puts it, in addition to the procedural considerations, limits on the role of a clinical ethicist's religious worldview should play in her consultative approach. They are supported by respect for patient autonomy. Respect for autonomy requires that a patient, or surrogate on his behalf, be empowered to make decisions based on his own worldview without manipulation or undue influence from others. This account of autonomy, I think, is misguided in at least two ways. First, it participates in what Bishop and Childress call a quote-unquote long-standing misinterpretation of their theory. Several critics, they write, have maintained that our book is committed to an American individualism in which the principle of respect for autonomy dominates all other moral principles and considerations. This interpretation of our book is profoundly mistaken. In a properly structured account of biomedical ethics, respect for autonomy has no distinctly American grounding and is not excessively individualistic or overriding, end quote. So, Malek's account thus expects more action-guiding knowledge from patient preferences than principalism properly does or should. Second, and more importantly, as the quote from Bishop and Childress suggests, this account smuggles into non-public moral deliberation an account of the human person and public reason that is more reductionistic than even the Rawlsian account that is meant to apply to official political deliberation. By making autonomy roughly synonymous with patient preferences, with American individualism, this account sees any moral norms that are external or asymmetrical to patient preferences as potentially or actually harmful, and the term harm here is especially philosophically loaded. And crucially, this would include institutional norms. So, my concluding section, reasoning morally within institutions. In contrast to this position, I want to conclude by suggesting that institutional norms provide healthcare practitioners with traditions within which they can reason morally. Moreover, properly formed healthcare practitioners are those who have been trained to think within these traditions, and possibly even to engage in the archaeological work of uncovering the deeper layers of those traditions. This approach does not abandon principalism. Rather, it depends on principalism as a starting point, both for thinking carefully about institutional norms externally in relation to official society and its putative neutrality, and internally in relation to particular cases as they present themselves in the routine work of caring for patients. But I am probably the least qualified person in this room to suggest how exactly this looks in the training of medical practitioners. I'm not a medical practitioner, and I don't teach in a medical school. I'm not sure where in a medical education this kind of approach to healthcare ethics would fit, or how to integrate it into the training that practitioners receive in their continuing education in such a way that perhaps the surgeons operating on my wife would not make fun of it. Rather than teaching healthcare practitioners, I teach people who are training for vocations in the ministry. And over the past couple of years, I've been thinking about how this set of issues should shape the way I teach bioethics to those students. And I'll teach my introductory bioethics course again this coming spring. My goal at this point is to teach them the same basic things that I've kind of gone through over the past several times. So how healthcare practitioners reason using the principles. I'll give them some resources for understanding the main topics, bioethics topics in our contemporary life, and help acquaint them with the conversations that will be taking place among the healthcare practitioners in the hospital when they go to, say, visit a parishioner there. But I'm also going to devote a portion of the term to helping my students think about the tradition context within which these practitioners work so that they can be better pastors to their parishioners with healthcare-related vocations. Helping my students pastor doctors who inhabit institutions with particular traditions is the task I hope to take up in the coming years. But I'd welcome your thoughts on how to train those doctors to better inhabit their institutions. And perhaps we can take that up during the Q&A. But for now, thank you very much for your time.